a medical advisor to the United Mitochondrial Disease Foundation and is on the UMDF Scientific and Medical Advisory Board. He has just been elected as president of the Mitochondrial Medicine Society and is on the Scientific Planning Committee of the Child Neurology Society. He serves as the clinical co-chair of the Cleveland Clinic Autism Standards Committee and is a member of the Cleveland Clinic Child Advocacy Board. Please join me in welcoming Dr. Parikh.
Well, good morning, everybody. Thank you for being here. I just wanted to quickly see a show of hands. Has anybody heard this talk before? I gave it in, I think, '08, and then at some of the UMDF meetings that we go to. Oh, Fran. Fran's from Cleveland. She's was one of our nurses and has always been Dr. Bruce Cohen's nurse, so she's heard this talk plenty of times. Anybody else? Okay. I just wanted to give those individuals a heads up that there's plenty of new material in here, so even though the base structure is the same, there is some new things there are some new things for you. But let me quickly get started. Just first, disclosures as a formality. Pretty much nothing that I'm really going to talk about today, though, interferes as far as the conflict goes. And so whenever I talk about mitochondrial disease, I use the analogy of entering a scary but brave new world, that the disease itself is confusing, and the road to diagnosis has unfortunately been very long, that it's full of biochemistry and genetics, both of which can be complicated experiences, not just for parents and families, but even for doctors, and this can all be very daunting, but that with some brains, some courage and heart, which I know that all of you have, and most doctors, and the help of some biochemical wizards, that we can help get all of us to the end of the mitochondrial brick road. So first off, why is such a scary, brave new world? And a lot of this really comes down to knowledge and a lack thereof, or lack of it. We've only really known about mitochondrial disease since the 1970s. Research really didn't take off till the 1990s to 2000s, and there have been phenomenal large changes that have happened just in the last 5 to 10 years in the time that I've been doing this, and it's a wonderful time to be doing this, and I think that's very hopeful, but at the same time, things like diabetes, which we've known about since the BC times, things like Alzheimer's, which we've known about since the 80 times, but still only 100 or so years, you kind of see the type of advances we've made in those diseases, and mitochondrial disease still has a lot of catching up to do. Add to that, to the older adage of mitochondrial disease affecting individuals of any age, causing any symptom and almost any disease, and that leads to a big challenge for physicians who want to try and get a wrangle on what mitochondrial disease is, and they can't when something is this broad and diffuse. I've discussed cases before, and just because of time's sake, I'm not going to discuss a lot of cases, but I want to give you a flavor of how mitochondrial disease can present. And I use a story of a 20-year-old girl who was a valedictorian and was in college early admission, was getting straight A's. She developed the first serious viral infection in her life, got dehydrated just by not eating or drinking a lot for 8 to 10 hours, and she ended up in the intensive care unit and liver failure and having prolonged seizures that were difficult to stop, and she was fine until she was 20, and she had this disease known as Alport syndrome caused by a mitochondrial gene being affected called POLG. Other examples I've used include a 3-year-old who's had regression in gait during a febrile viral infection, was completely fine before that, and ended up having mitochondrial disease diagnosed, as well as a 34-year-old woman who was completely fine till I think her second pregnancy, where after delivery she ended up having multiple strokes, and she was identified as having something called Mila syndrome. When doctors hear of this wide variety, as far as presentations go and ages go, it sometimes very much shocks them because there are not that many diseases in medicine that present in such a way. Add to this mitochondrial disease, sometimes presenting with what we call idiopathic autism, just isolated developmental delay, severe epilepsy, isolated kidney disease or something called adrenal insufficiency, and it just adds to the layers of challenges that physicians can have understanding this if they are not specialists, if they're not doing this as far as as their primary job. As far as families go, this also adds to the confusion of, does my child, does my family member have mitochondrial disease when diagnostic challenges remain, and I'll touch on those. But kind of froze. That's never happened before. Just give me 10 seconds to try and reload this. I'm not quite sure what happened. There we go. No, it looked like the computer just froze. It's definitely unfrozen. It should be coming back up. There we go. Okay, so sorry about that. So before we actually start talking about mitochondrial disease, though, we've got to have a little bit of a foundation. And so we're going to go and get the scarecrow his brains and give everybody here in the audience some smarts. So before you go and visit a brave new city, you're going to need a roadmap. And here's your roadmap of mitochondrial disease. So mitochondria have been with us for eons, but in fact, they have a prehistoric origin, they have a bacterial origin, and it ends up being very important to how mitochondria and mitochondrial diseases manifest themselves. And there is a growing and growing interest in studying how mitochondria are like bacteria and not like bacteria, because how we combat bacterial infections and illnesses, for example, antibiotics, can affect mitochondria because of their similarities. And being able to understand these differences may help also lead to treatments or just novel diagnostic testing. So this is one very big area of study. As far as mitochondria themselves go, we often, at least when we had biology class, we were given a picture of one little mitochondria sitting inside the cell, and that's in fact not true. Each cell has hundreds to thousands of mitochondria, and then we've of course got trillions of cells in our body, so we've got gazillions of these things that are living, breathing, dying within us, and we're building new ones and repairing old ones, and this number of mitochondria is constantly fluctuating depending on the needs of the cell and the needs of the body. What role do they play? You know, we always talk about the energy factory, and that's a very important role, but I want to emphasize the mitochondria do a heck of a lot more. So the mitochondria are the cell's assassins, that when the cells start getting unhealthy, there's a whole cascade messaging system that gets signaled that ends up waking up the mitochondrial killers, and then the mitochondria end up killing off cells, and that's one of their most important jobs. And we know that that job is sometimes affected in cancer. We know that mitochondria create and destroy what are called free radicals. Think of free radicals as little chemical bombs or mines that are created from just normal biochemistry, chemical reactions happening inside the cells all the time. These mines, unfortunately, if we can't take care of them, get misplaced and they end up going off right next to an important part of the cell, like DNA, or sometimes impeding just normal chemical reactions. And unhealthy mitochondria make more of these things called free radicals, or are not able to effectively get rid of free radicals as part of their day-to-day duties. And then, of course, mitochondria do take all the fuel that we give the cells, whether it's in the form of pasta or donuts, churning all this into proteins and amino acids, organic acids, and something called Krebs cycle intermediates, distilling it all down into the energy factory or the engine of the cell. And doctors are used to seeing the energy factory and some of the components before it distill down into a chart like this. But what I do want to make a point of is saying, we always think about the energy factory, complexes 1 through 4, and you guys may have heard those terms before. It's, in fact, not that important whether you understand what those various complexes are, but when you only talk about the energy factory, but in fact, this is everything that's going on inside the mitochondria. And there's a heck of a lot more to understand than just the energy factory role. And we know that disease can happen not just because of a breakdown in the energy factory, but other problems in and around as far as the hundreds of other things going on. But the energy factory is important, and we know that in most patients with mitochondrial disease, it is dysfunction of the energy factory itself. And we used to always draw the energy factory, and in biology books and classes, colleges, schools today, it's still drawn like this, like little buildings lined up in a strip mall. Complexes 1, 2, 3, and 4, and then little parts getting passed down from one to the other so that it can enter the rotor that's known as complex 5 and allow us to make energy. But life is not simple, and our understanding of mitochondria as it's evolved has showed us that the mitochondria are not organized in such a simple fashion. They are, in fact, thrown together like this building, and they're called supercomplexes. And these supercomplexes, we have to have the foreman involved in telling the body and the cells how to build the mitochondria into these supercomplexes. And we know that if we can't build supercomplexes properly, even though every single component of the mitochondrial energy factory is intact, the inability to bundle all this together, glue all this together, can lead to human disease. And this is an actual live, real picture of what a supercomplex looks like inside the cell. The supercomplexes, again, then are organized into bigger blocks or city blocks called supracomplexes, and this organizational structure, just like engines lined up back to back or machinery lined up back to be efficient, is important. This is important inside the cells as well, and if we can't do this, mitochondria don't make energy effectively. Mitochondria do have bacterial origins, and just like bacteria, they're able to fissure apart and fuse together. These are the only parts of our cells that can do this. And we now know that problems in being able to fuse things together and fuse things apart or fissure things apart can lead to human disease, because why do mitochondria do this? One of the reasons is so that they can merge together, trade broken things for new things, and then fissure back apart and then go about their independent existence. We used to think of mitochondria as being these stationary, quiet things, but in fact they're not. Mitochondria are tethered to the cell wall. We know that that tether or leash, when it gets yanked, can set off that death cascade to allow the mitochondrial assassins to wake up. That mitochondria are able to talk to other mitochondria using chemical signals, and mitochondria are also able to talk to the nucleus or the central hub of the cell. And we know that messaging problems here can also lead to disease. And so here is just an example of mitochondria crossing over to something called the endoplasmic reticulum and going and actually communicating, though what they're trying to say we don't really know yet. Mitochondria are also call to action wherever the cells need them. And so this is basically a nerve cell called an axon, and the mitochondria are traversing down from one side to the other to the part of the cell that needs the most energy. And so this ability to walk or run is sometimes impaired in mitochondria. And when you can't get the mitochondria to where you need them, even if they are perfectly healthy in every other way, you get disease. And then this is just another example of where mitochondria are bundled together in areas of the muscle where there is a higher need. So this has all been, if you look at some of the dates at the bottom, most of this research is less than 5 years old. Much of this research has been presented here, and the UMDF is crucial in funding and supporting all of this research, but this has very much built our understanding of what mitochondria do for a living. We think of mitochondria and energy and cellular energy, but sometimes even doctors forget what the heck we need cellular energy for. We all realize chemical reactions need cellular energy whenever we learn chemistry and biochemistry and organic chemistry, but practically speaking, you need energy for all of these processes, from hormone synthesis to immune cell function to making DNA and DNA counterparts. And without enough energy, all of these areas can and do unfortunately suffer. Mitochondria are also now being well recognized as propagating inflammation, especially when they're not working well. Now, this does not directly translate into mitochondrial patients have more illness. or infections, but this is basically another area of study. And I'm just trying to expand your understanding of what the heck mitochondria do for a living, just so that you can understand that unfortunately it's not as simple as the energy factory is broken, why can't we just fix the energy factory? Because there's all these other things going on at the same time that we still have to understand before we can just unravel exactly what parts of the cell that we need to fix. They are the only parts of our body that have two sets of blueprints. And what do I mean by that? I use the analogy of thinking of DNA as a set of books that the body and brain use to build and maintain themselves, and the mitochondria. And we all talk about something called nuclear DNA. Nuclear DNA is regular DNA. You got half from mom, half from dad. This book is a very big book. It's about 30,000 genes or chapters in size. It has about 2 trillion letters from front to back, and you only need a single letter typo in any one of those 2 trillion letters to lead to human disease, depending on where the typo is, what that chapter does for a living. If it's involved in building the mitochondria, you get mitochondrial disease. If it's involved in building the brain, you get brain disease. And the mitochondria need regular DNA. 80% of what the mitochondria need comes from regular DNA. And this is one of those other take-home points, that mitochondria do more than just make energy. And then 2, they need regular DNA. Regular DNA comes half from mom, half from dad. As far as of those 30,000 chapters or genes, how many are involved in building the mitochondria? We think about 1,400. And when I first started doing this, which was only 8 years ago, we only knew of about 20 genes or chapters, and that number just in the last 8 years has grown to about 1,200. And that's a phenomenal amount of growth and knowledge that has happened, but we've still got a little bit of ways to go. But I did mention a second blueprint. And so the second blueprint is something called mitochondrial DNA. Now, unfortunately, mitochondrial DNA has gotten too much press. We've learned about mitochondrial DNA. There's this fancy DNA that goes from mother to child. It's involved in building the mitochondria, and that's true. And you do not get your just your mitochondria from your mom. You actually get your initial copies of your mitochondrial DNA from mom. But mitochondrial DNA are not the only things responsible in helping build the mitochondria. Only 20% of what the mitochondria need to function come from this little blueprint. Now, I did say regular DNA is this humongous book of 30,000 chapters. Mitochondrial DNA is a compact little thing of 37 chapters. And because of its compactness, I think it got studied first and more knowledge developed about mitochondrial DNA. But we've known since the 2000s that mitochondrial DNA is, while crucial for mitochondrial function, not the end-all and be-all. But what else have we learned? We've learned that we actually have a filtration system in place, that when you look at immature eggs inside the body, that there are 100,000 copies of mitochondrial DNA. But by the time that you actually get down to the organism, the mother has only passed down 50 of those copies to the child. And why is that? Well, it seems to be a filtration system to allow us to weed out unhealthy copies of mitochondrial DNA. So you get 50 copies of mitochondrial DNA from your mother. Hopefully, most of them are healthy. We've also understood that if you just look at normal healthy babies in a nursery, that 1 in 200 might actually carry a typo or mistake in their mitochondrial DNA that could lead to mitochondrial disease. And this was a very elegant study done by Dr. Chinnery's group in 2008. He's a PhD researcher who's been very active in mitochondrial research. And this number kind of blew everybody, woke everybody up. That does not mean 1 in 200 of those babies will definitely have mitochondrial disease. It's just that that potential is there. Depending on what happens to those children in their lives, what other contributing genetic or environmental factors exist, they have the potential of developing mitochondrial disease. And this number was very important in waking up scientists, waking up researchers, and allowing us also to potentially gain more funding for mitochondrial disease research. We've also learned that mitochondria do have bacterial origins, and they are their ancestry is very important to how our bodies work. And so your mitochondria come from different parts of the world depending on where you originated from. And unfortunately, some parts of the world carry more disease burden in their mitochondria for certain diseases, while other families carry other disease burdens depending on where the mitochondrial DNA originated from. So their ancestry is very important. What we are understanding is that mitochondrial DNA and this term called haplogroups, where your mitochondria come from, affect regular disease. Why is one family's diabetes 10 times worse than another's? Why is one family's heart disease worse than others? Why do some people respond to cancer chemotherapy and some people don't? Some of that can be explained by where your mitochondrial DNA originate from. Not all of it, but some of it. And understanding this relationship better has been an area of study and growth. But take-home point, mitochondrial disease is not all maternally inherited. That's true at least 1 out of 5 times, but most of the time the problem is in regular DNA, and our understanding of regular DNA chapters that contribute to mitochondrial disease has grown tremendously, allowing us to get closer to answers. So this is basically a summary of a lot of everything we've learned that's allowed us to create a visualization of what the heck the mitochondria are doing for a living, and I just want to take a minute to show you guys this. So far, we've just been seeing all the other things that go on in the mitochondria. Here we're filtering down to what are called the supercomplexes. These are components of energy, chemical energy being made and then translated, going down the different complexes. Coming to what's known as complex 5, which is the rotor, and where the magic happens, where we take electrons and water and create the energy we need for life. And our ability to visualize this in 3D is something we never had before about 3 to 4 years ago. Okay, so you guys have your map of what the heck mitochondria do for a living. And now it's time to take the next step. So what is mitochondrial disease and why does it happen? So remember, there's these gazillion mitochondria that are inside of you. Each organ's got its own pool. And it's not that all of them are unhealthy in mitochondrial disease, most of the time. It's that there's a mixture. A certain gazillion are unhealthy and a certain gazillion are healthy. And when that balance shifts, when you end up having more unhealthy than healthy, your cells in that organ can develop energy failure. This is not permanent. It's a fluctuating thing. There is some energy failure. There's a brownout in the electrical grid that can be restarted back up. There can be all of these cellular pathways that you were seeing, and I talked a little bit about, can be affected, and cell death can sometimes also happen prematurely. And when that happens, you get a lot of organ systems being affected depending on where these brownouts are happening. Now, it turns out that 20% of the energy made by mitochondria are needed by the brain. And so the brain, unfortunately, is affected most commonly. It's why neurologists have gotten very interested in mitochondrial disease. But then there's just a laundry list of other parts of our body, and unfortunately, we could keep going on with that list because there has not been a part of the body that's been spared a mitochondrial problem. But there is kind of a pecking order, and we do know which organs seem to be more involved than others. Why? That we don't quite understand, why your liver is more affected than, let's say, your gallbladder, and we don't really know of that many problems inside the gallbladder from mitochondrial energy dysfunction, so this may just be limitations in our understanding, or there may be something going on inside the mitochondria in the gallbladder to keep disease from happening. Now, why do we actually get unhealthy mitochondrial pools developing? And this brings up an important concept that is important for you to understand, and there's something called primary versus secondary mitochondrial disease. And what do I mean by that? Primary has to do with DNA. There is a typo in the DNA building blocks or in one of those chapters that keep the mitochondria from being built properly, and because of that, you're making unhealthy mitochondria that are not working up to speed. And that's what we call primary mitochondrial disease. But then there's also this thing that we've understood called secondary mitochondrial disease or secondary mitochondrial dysfunction. And this has to do with, think of that a factory building can be built perfectly well, but if there's a tornado going on outside of it, you can't have that factory building working up to speed even if it wants to. And this is true for the cell and the mitochondria as well. Other problems inside the cell from other disease can impact and impede mitochondrial function. And so, doctors have always kind of known about this. When you were at your sickest, when you're in the intensive care unit, your whole body's, going to pot, that your organs are starting to shut down, and the mitochondria, if you think of them as an organ, are starting to shut down as well. We never call that mitochondrial disease because we just thought, boy, somebody's critically ill, their mitochondria are shutting down. And so when we used to find mitochondrial dysfunction in these diseases, we never thought of it as an inherent or direct mitochondrial problem. Then the study of drug research, as that grew and evolved, people started looking at the effects of drugs on mitochondria and mitochondrial function, and the list of drugs that can impact mitochondrial function in a cell, not in a human being, in a cell, in a petri dish, is pretty big. And it started growing, and we started saying, wow, look, these little things, they're so vulnerable to all these other outside influences. Could human diseases also do this? And so a lot of research that happened in the diseases of aging, Alzheimer's, diabetes, Parkinson's, the same things started getting identified. That people who had Alzheimer's for 30 years, 20 years, diabetes for 30 years, that their mitochondria were a lot unhealthier than just somebody who was not affected with those conditions. And then people started looking at pediatric conditions and diseases, rare metabolic disorders. And this list has continued to grow, so that I've actually had to add a disclaimer at the bottom saying this is not a complete list, because I would get people saying, well, what about this condition? And I would have to say, yes, we know that mitochondria can be affected in this condition or that. And people started looking at genetic conditions. And there's a whole slew of primary other genetic diseases that have nothing to do with how the mitochondria are built that lead to mitochondrial function getting impaired. And something as simple as starvation. There have been some very elegant studies done in people who are cachectic, very malnourished from things like, not like cancer, but from just chronic illness or anorexia. And when you look at the mitochondria in those individuals where they're not sick in any other way, they're malnourished, you end up looking at how their mitochondria work at point A, and then you replenish them, renourish them, and look at their mitochondria at point B, that the mitochondria go from unhealthy to healthy. So this is very important in our patients who sometimes are feeling sick, nauseated, not eating or drinking well. We don't know why, but they're not, and they're malnourished, and we're trying to study their mitochondria. Or when kids have something called failure to thrive because of swallowing problems or reflux or problems with weight loss or weight gain, and we're studying mitochondria. Because in all of those conditions, if you find unhealthy mitochondria, it doesn't necessarily mean mitochondrial disease. We've got to exclude all of these other diseases in a practical way. Some of them are treatable, and we cannot miss treatable diseases. Two, if not treatable, they're at least treated very differently than mitochondrial disease. Or, if nothing else, many of them have a very different prognosis. And so our biggest job has become, when you come to a mitochondrial disease clinic, is saying, okay, I hear that you're worried about mitochondrial disease, and that's a practical concern and consideration, but you know what? Let me make my list of everything else that might also mimic this, that might cause these problems, and we've got to do our due diligence and try and take off as much as we can off that list. And I'm going to get to why this is even more important now in the age of genetics, because as our genetic knowledge has improved, we're finding more and more patients who we thought had mitochondrial disease actually don't. Okay, so you've got your roadmap, you understand what mitochondrial disease is, so it's time to actually look at somebody who might have mitochondrial disease. And we're going to focus just on primary mitochondrial disease, right? Because all the secondary diseases, your doctor is going to be smart about ruling out. So primary mitochondrial disease, like I said before, predominantly is inherited from regular genes. It can be a new typo in the child or patient's DNA That happens. We have 100 to 200 changes different from our parents. Sometimes it just makes us quirky. Sometimes it actually causes disease. And or some of the time, mitochondrial diseases can be inherited from mother to child, but that is not the bulk of the time. Now, the challenge has always been for doctors, how do you wrangle a disease that can cause so many different symptoms? And the adage when I first started doing this was, well, it's a common disease with atypical features. And, that's kind of true, but it doesn't help me much when I'm sitting with a patient in clinic trying to figure out what's going on with them. Another older adage was, well, there's more than 3 organ systems involved. And that's in fact very true for mitochondrial disease. But you know what? By the time 3 organ systems are involved, you've probably missed the boat and you should have picked this up a long time ago. So this is something that's helpful, but not helpful enough. Recurrent setbacks and flare-ups with routine illnesses and exposures and illnesses, this is very true, and I think this still holds true, and it's something that doctors really need to consider. Now, this is not true just for mitochondrial disease. It's true for any cell chemical disorder like metabolic disease. So a group of us that are in something called the Mitochondrial Medicine Society said, you know what, we've got to try and help doctors focus better at what they need to look at to worry about mitochondrial disease. Now, this list is a list that we just culled from everything in the literature. Nobody had just thrown, this is stuff that was already out there, but it was very hodgepodge, and it wasn't all just put together in a nice little table, and that's all we did. We're not taking credit for finding any of these individual symptoms or problems, but what we created was first something called a red flag list that doctors really need to worry about. Now, this is all available for free on the Mitochondrial Medicine Society website. You can just Google Mitochondrial Medicine Society. It'll take you there. There's a tab called Toolkit, and when you hit the toolkit, you'll get access to all of these tables in case anybody's interested. So what are the red flag symptoms? Going through them very quickly. Pretty much any brain disease, but as far as brain disease goes, there's something specific. If you've got strokes, actual injury in the brain that can be seen on an MRI that happens in a non-blood vessel distribution, we've got to worry about mitochondrial disease. If the deepest portions of the brain, called the basal ganglia, one of the most ancient portions of the brain, are involved, both sides, left and right, at the same time in about the same intensity, other than mitochondrial disease, the list of things that cause this is very short. If your cerebellum, your balance center, is shrinking and getting unhealthy, you need to worry about mitochondrial disease. Something called myoclonic seizures, a type of seizure disorder that just leads to repetitive jerking of the whole body or just a part of the body, you need to worry about mitochondrial disease. Hearing loss that is unexpected and earlier than expected for age, whether it is because of the nerve being damaged or the brain not working well, you need to think about mitochondrial disease. Changes in the net in the back of your eye, called the retina, that catches the light and translates those signals into electricity for the brain to interpret. If there's a problem there, especially a type of problem called retinitis pigmentosa, you need to worry about mitochondrial disease. If there is a problem controlling eye movements or eye muscles or at the eyelids, you need to worry about mitochondrial disease. Now, these are not the only diseases that will cause, mitochondrial disease is not the only disease that will cause this problem, but it's one that should be somewhere on that doctor's list. If you have a problem with being too short for your family, not just absolutely short, but if everybody in your family is 5'10" and you're 5 feet tall and nobody has given a good explanation for that, you need to worry about mitochondrial disease. If you have problems with weight gain, despite eating adequate calories or getting adequate calories delivered to you in some way or another, you need to worry about mitochondrial disease. If you have a problem with your heart rhythm working properly, what are called cardiac arrhythmias, or problems with your heart muscle getting too big, something called cardiac hypertrophy, you need to worry about mitochondrial disease when no other reason or explanation has been found. If you have a problem with something called motility, being able to move all your food down your gut into your colon because it's either not going fast enough or going too quickly, you need to worry about mitochondrial disease. We rounded out the list when we looked at the literature as far as primary mitochondrial disease causing symptoms. If you have severe hypotonia, low tone, being an extremely floppy baby, doctors sometimes use the description they were loose like a dish rag. You need to worry about mitochondrial disease. If you have unexplained liver disease, that's getting worse. I throw exercise intolerance on there, but for doctors, this means something very different. This just doesn't mean I get tired easily when I work out or exercise or exert myself. This is being able to throw somebody on a treadmill and measure what's called oxygen consumption, and they have what we can call documented exercise intolerance on the treadmill. That is a very important sign of mitochondrial disease, where you're not using oxygen effectively, presumably because your mitochondria may not be working well. If you have poor waking after generalized anesthesia, and we're not talking about waking up agitated, we're not talking about taking an extra hour or two from waking up from anesthesia, we're talking about taking an extra half a day to a day for a same-day procedure, and they have to keep you overnight because you just couldn't wake up fully. Or if you end up spending a week in the hospital for unclear reasons after anesthesia, especially because you're not waking up fully, this has been seen with primary mitochondrial disease. And this list has been thrown together on a chart just for people to be able to reference easily. There are some supporting symptoms that we look at, and I'm not going to go through each one because of time's sake, but there is a chart available online as well in case you want to access it. And there are some variant phenotypes that people have identified. We know that some patients with cyclic vomiting syndrome have unhealthy mitochondria. We are also learning that those patients do not follow the classic syndromic mitochondrial disease path, meaning they don't develop other organ involvement or other symptoms, they just have cyclic vomiting. That we know that if you've got schizophrenia plus seizures, you might have mitochondrial disease. If you've got dysautonomia that remains unexplained, where your autopilot system in the brain is not working well, your ability to control blood pressure, heart rate, gut movements, and is getting unhealthy, mitochondrial diseases might be associated. We know that if there is a maternal inheritance pattern of something, it is clearly going from mother to child in the family, and men are not being able to pass this on, whether it be migraines or whether it be a variety of other diseases. It's clearly most likely a mitochondrial disease. We know that some patients with autism, especially what's called a regressive subtype of autism, where after the ages of 2, you end up losing abilities that you had truly acquired with or without a trigger, that some of those patients may have mitochondrial disease. We know that, as I had mentioned before, that if you deteriorate with routine illnesses, routine things that your body should be able to manage without a problem, you may have a metabolic disease, including a mitochondrial disease. And then also if you can't fast overnight well, and by this we don't mean just waking up feeling a little bit woozy, but we often hear stories of people who've woken up every night at 2 or 3 a.m. to have a big turkey sandwich, and they've just done that since they were 10 years old or 8 years old, and they never thought otherwise of it because they were just the person in the family who did it, and their bodies were telling them to prevent fasting by having this huge meal in the middle of the night. They weren't getting up just for cookies or the last, chicken wing. They were having a sit-down meal. A mom who might actually have excessive vomiting, something called preeclampsia or severe fatigue, where they are bedridden during the pregnancy. This is what we call a soft risk factor for mitochondrial disease. And then a maternal inheritance pattern of psychiatric disease, whether it be bipolar disease, depression, anxiety, panic attacks. We know that this is seen more commonly in mitochondrial disease family clusters. A family history of sudden infant death, children dying in infancy for unclear reasons, or short stature, we do consider mitochondrial disease as a possibility. All right, so now you've got the map. You know what mitochondrial disease is. You know what you're going to look for in your own family members or patients, or tell your doctor to look for in their clinic. How are we going to actually diagnose this problem? So diagnosis has always been a challenge, and it is something that is becoming less of a challenge, but it still remains a scary thing. It involves a lot of biochemistry and genetics, which not just for families and lay people is difficult, but even for practicing physicians. This was something there, in medical school, you basically spent a tiny bit of your time on. And unless you got interested in this, you really didn't learn enough. And so we say in those situations, you guys don't have to worry. Let us as biochemical or genetic wizards help out, and so that we can kind of take this diagnostic witch and put her in her place and get closer to an answer. There's a top 10 list I've started handing out to my families in clinic that I think some have found helpful. and I'm just going to quickly walk through it. One is that mitochondrial diagnosis is unfortunately a marathon, not a sprint. That mitochondrial disease is underdiagnosed, that there are many physicians who do not consider mitochondrial disease as a possibility until 3 organ systems are involved. And that's a challenge. But unfortunately, in some communities and or in some practices, mitochondrial disease is also being overdiagnosed. And what I mean by that is doctors are taught to make lists. It's something called differential diagnoses lists, that when a problem happens, what's the top 10 things that could cause it? And we're taught to rank all of those 10 things equally and use a set of logic to try and, have one sift to the surface and have the other things kind of fall off our list. Well, what's happening for some reason is that when doctors consider mitochondrial disease, they seem to get blinders put on and they let all their other things off that list kind of just fall off without doing their due diligence. And mitochondrial disease seems to float to the surface. And time again, we're getting patients in clinic where somebody said, oh, my doctor thought it was mitochondrial disease. They did some mitochondrial testing, and we found this abnormality, so I must have mitochondrial disease. And we would say, well, what about conditions A, B, C, D, E, F, G? And they're like, nobody looked. And we don't know why this is happening, but this has been happening a lot in the last 5 to 10 years. And maybe in our advocacy and in our effort to educate people about mitochondrial disease, maybe not that we've gone overboard, but maybe our message has not been as tempered as it needs to be, because while it is underdiagnosed in many places, in some centers, it's just getting thrown to the top of the list too quickly. We know that blood and urine testing has what's called a low sensitivity, meaning it can miss an answer. So just because your blood and urine testing is normal doesn't take mitochondrial diseases off the list, unfortunately. But the problem is something called muscle testing has what are called false positives, meaning you can find unhealthy mitochondria in muscle, but it does not mean automatically that you have mitochondrial disease. To add to this complicated list, DNA testing has improved, but it is still imperfect, and I'll get to why. And all this data is needed, unfortunately. We need to have all of this information, and one abnormal result is usually not enough to say somebody has mitochondrial disease anymore. And I don't think it ever was true, though we just didn't know better. And except for a known disease-causing DNA problem. That's different. But outside of that, we kind of need to look at the big picture. Okay, where do we start? We should start not with things like muscle, but with what doctors usually start with. You go and complain of a sore throat, they do a throat swab and a blood test. Well, doctors for mitochondrial disease should be doing the same thing. Now, there are some what are called acronym-based diagnoses. These were some of the earliest mitochondrial diseases identified. Most doctors don't memorize these acronyms unless they see a lot of mitochondrial disease patients, and you as families shouldn't have to either, but we do warn docs saying, you know what, if you recognize one of these acronym conditions, you can make the diagnosis quickly in blood. So make sure you keep your eye open for one of these. But if you don't see this, and most patients don't present with this, they present with a hodgepodge of what we call red flag symptoms, plus some of those other supporting player symptoms, you've got to start with blood, in urine, and sometimes spinal fluid. And so we do recommend starting there. And we have a list put together for docs and for families of what we look at. I talk a little bit, usually depending on the time, about something called lactic acid. It gets measured a lot because in mitochondrial patients, lactic acid is often abnormal, but it is not a reliable marker because lactic acid can be abnormal in a whole host of other situations, and it can mislead us. And so there are a lot of other things that we look at besides lactic acid that are a lot more reliable. And then we've rounded out that with kind of, like I said, doing our due diligence, checking all the other organ systems that might get involved in a mitochondrial disease patient, making sure that we've ruled out other conditions that could mimic mitochondrial disease. We even have a plan on the website about what to do when the initial testing is normal. And I'm not going to go through all of this in detail today, but there are some tricks we can use to try and bring out a mitochondrial problem. What's the challenge here? No matter what we find in blood or urine or spinal fluid, it tells us, yes, the mitochondria might be unhealthy, but it doesn't tell us why. That person with diabetes for 30 years, that person who might be getting poisoned with carbon monoxide but doesn't have a primary mitochondrial disease, or that person who actually has primary mitochondrial disease can all have the same set of lab data. And so that lab data by itself is not enough. It may help us focus the genetic testing, and this is the first time we can actually say that this is important because our genetic testing has grown in leaps and bounds. And the ability to make a genetic diagnosis is better now than it ever was before, and it's wonderful to be able to say that. Now remember, I said there's 30,000 genes or chapters in human DNA, and about 1,200 or so are involved in building the mitochondria. And then on top of that, we've got a compact little blueprint called mitochondrial DNA, right? 37 chapters. Well, if you've got one of these acronym problems and your doctor recognizes it, most of these are caused by the mitochondrial DNA being unhealthy, the thing that goes from mother to child. These 37 genes or chapters, we can look at it from front to back for single letter typos or mistakes for relatively cheap. And so this is called mitochondrial DNA genome testing or sequencing. And there are truly a dozen or so labs easily that offer this. And each one has their strengths and weaknesses. Many of them have their booths here outside. But this is something that we can do very easily, looking at the mitochondrial DNA. And it is something that is often warranted in many of our patients before doing anything more invasive and should be considered. Genetic testing ability up till 3 years ago used to be a single gene or DNA chapter at a time. Even if we made a list of 10 DNA chapters where we were worried about a problem, out of 30,000, that's just a drop in the bucket, and each test used to cost a couple $1,000s. And so our ability with something called chip-based sequencing, or a DNA chip-based sequencing, the name that is formally used is called next-gen or next-generation sequencing, has allowed us to take areas of interest, DNA chapters or genes of interest, put them on a microchip and look at them from front to back for single letter typos. And for mitochondrial disease, what exists? There is a 100+ gene panel available that takes everything that, all the known genes or DNA chapters that cause 90% of known human mitochondrial disease. There is a 400+ gene panel available, and then there is going to be, but not yet, an 1,100+ gene panel that's going to become available. And most of these are going to be, again, in the world of DNA testing, relatively reasonably priced, which is less than $7,000. Remember, each single DNA test used to cost $2,000. So when we can look at 100 or 1,100 for 7,000, that's wonderful. But the other kind of earth-shattering thing that's happened in the world of genetics, oh, I'm getting ahead of myself, but I might as well mention it, is something called exome sequencing. And the exome is all 30,000 chapters. Now, this is a test that is not ready for prime time. This is truly, it's available. It's available to you and I, but it is not ready for prime time because anytime you look in DNA, anytime you look at anywhere in the body, actually, we've all got quirks. We've all got a cyst here or there, and then your doctor has to tell you, well, yeah, you've got a cyst inside your inner ear, and it'll probably do nothing, but I've got to tell you about it because the report lists it. Well, DNA is the same way. Our DNA is littered with typos. We've got 3 trillion letters, and all of these typos are not bad. Some typos, you come from France, and the French people have these typos more commonly. If you come from the UK, you might have a different set of typos. And sometimes when these labs identify typos in DNA, they are able to tell us problem or not a problem. But as far as looking at 30,000 genes or chapters and finding typos, we are not that smart yet, nationally, internationally. And so there is a danger and a practical reality that if you get this thing called an exome test today, you may get, or actually you do end up getting a 20-page report that says, we found a typo here, we don't know what this means. We found a typo here, we don't know what this means. Ad nauseum, 20 more pages. And what do we do when we're sitting with you in our office and saying, okay, they didn't find anything meaningful, but they found 20 pages of all of these typos, and you're going to have to sit down with us every year so that we can go through these and make sure none of these cause disease. So for many of our patients, we say, you know what, we're going to do this in an educated, stepwise fashion, and as our testing and knowledge improve, we might get to this fancy, powerful test called exome sequencing. It's just not ready for prime time yet. But these things are moving very rapidly. Exome testing went live end of last year, 2011, and we expect that it's probably going to become a second or third line test in 5 years' time. So a lot of what we're talking about today, doing this in a stepwise fashion, will still be available to us and will probably still be done for many of our families, but we will quickly have a powerful tool we can jump to if we strike out after our first 1 or 2 tests. Dr. Mutha, Dr. Calvo, Dr. Thorburn, who are here, and some of them were talking about this just today, they looked at, with some of this neurotechnology, all 1,200 known genes involved in building the mitochondria. And they found, when they looked in infants who had chemical evidence in blood, urine, muscle of mitochondrial disease, about half the time they were able to find a primary mitochondrial disease cause. Now think about that. 100% of these families were thinking they might have a primary mitochondrial disease because their blood, urine, or muscle showed a mitochondrial problem. But when we looked at all the known genes identified in mitochondrial disease, and we're only a couple hundred short now as far as knowledge goes, only half those families had a primary mitochondrial disease identified, which means what's going on with the other half? The other half either A, do not have a mitochondrial disease, which is probably true for the bulk of them, or two, a smaller percentage have a mitochondrial disease because of DNA genes or chapters we haven't identified yet. The adult numbers are even worse. Only 15% of the adults had a primary mitochondrial disease identified. So there's a whole lot of a knowledge gap that still exists. And there's a whole lot of weakness in our testing in blood and urine and muscle, which as a doctor, it makes it incredibly frustrating. As a family or a patient, it's enough to make somebody cry. The other thing is they used a very selected population. They wanted to increase their yield. So this is not all their patients who had mitochondrial problems. They, as they're allowed to do, cherry-picked what they felt was going to be the highest yield pool of their patients. So this is not even all comers, you know? They picked and chose who they tested. Okay, that's the exome sequencing test which I talked about, which again, is already less than $7,000. Think about it, 400 gene panel for $7,000 or a 30,000 gene test. Once all the data crunching and numbers have been worked out, people are gonna be going to this eventually. But we often do have to look at muscle in many of our patients because gene testing does fall short. And sometimes even with gene testing, we don't always get to an answer, or we get an answer of finding typos where we're not quite sure what the typos mean. And we do have to study tissue to get to an answer. And because of time's sake, I'm not going to go through this in too much detail, but we can look in skin and we can look in muscle. And each of these tests has its problems. Testing in skin can miss an answer at least half the time. Testing in muscle can miss an answer 1 out of 5 times. And remember, even if we find a problem, it does not automatically mean primary mitochondrial disease. So we do not think it's a gold standard. It does not help with prognosis or treatment, but it is a stepping stone to get to a diagnosis. It's just an invasive way. So many of us think very much about doing it before doing it, making sure families understand the risks and benefits. And there were many people who were getting muscle biopsies done. We said, well, you know what? We didn't really find anything meaningful. And they'll say, well, does that mean I don't have mitochondrial disease? And we'll say, well, no, not necessarily. And the flip side also happened, where we would find some, what I call kind of ipsy-pipsy abnormalities, a little bit of this or a little bit of that. And they would say, well, does this mean I have mitochondrial disease? And we would say, no. And many patients used to say, well, if I had known that, I wouldn't have put myself through this, or I wouldn't have put my child through this. And so now we want to make sure that families understand the strengths and weaknesses of this testing before getting there. It may tell us that the mitochondria are unhealthy, that a certain portion is not working well, but it doesn't really tell us primary or secondary disease. It can help us focus the genetic evaluation even closer. There are some DNA tests that we can only do in muscle. Most can be done in blood, but there are some specific types, and it does not help us change treatment or prognosis. Okay. So many patients still end up with some hodgepodge of what we kind of call, a mouthful of words. You possibly have a primary or secondary mitochondrial disease that's biochemically proven, which, it's hard. As a family, as a doctor, having to hand out a diagnosis like that, it's hard. So you've learned about what mitochondria are, what they do for a living, what mitochondrial disease is, and how we're getting closer to finding an answer for many of you. But something that many of you and we are interested in is, well, how do we help? And so let's end the talk by talking about treatment. And the first thing we know is that we've got to increase, of these gazillions of mitochondria, some being unhealthy, can we shift the pool of healthy mitochondria? And it turns out we have a way of doing this. And this is the only proven way we have of treating mitochondrial disease, though it's going to be stuff you may not want to hear about. It's exercise, eating a healthy diet, and doing therapy, whether it's physical therapy or occupational therapy. It's some of the stuff that doctors have been touting for ages, and it is one of the only proven ways we have of helping you build a healthier pool of mitochondria. One, there have been many studies that have shown that exercise therapy is safe for patients who have mitochondrial disease. And there have been many studies done by people like Tanya Tavasalo, Mark Tarnopolsky, Ron Haller, some of who are here, that it is one of the few ways we have in mice and in humans of increasing your pool of healthy mitochondria. This may be why this helps prevent aging and aging-related diseases, because one of the reasons we age is because our pool of unhealthy mitochondria grows. And we know that if we can shift this to a healthier pool, why not? So this is one of Mark Tarnopolsky's studies where he's taken mice. Both of these mice have mitochondrial disease, DNA-given mitochondrial disease. One mouse from the litter is made to exercise, is forced to exercise. The other mouse is not. And at the end, when you basically take a look at these two mice from the litter, the one mouse that is forced to exercise, both physically and microscopically, when they sacrifice the mouse and study it, looks like a normal, healthy mouse, like any other litter. And then you take the one that was not forced to exercise, and he looks ratty. He has got, an ear that flops over, his fur is not rich, and then also microscopically, he looks pretty unhealthy. So this is kind of some of the work that Mark has done. We know that diet, we don't have specifics about diet, but we do know that ideal calories, eating frequent and small healthy meals, healthful meals, all the stuff that you know is bad for you and trying to avoid it. It's one of the few things we know that can help the mitochondria stay healthy. The other thing that we shouldn't overlook, because it's very simple, and because of how simple it is, it does sometimes get overlooked, is preventative care. We don't want to hurt our patients. And so if there are things that we can pick off before they're getting worse, following a person's hearing and trying to help them when their hearing starts getting poor before they're actually deaf. It is something that's very important. Making sure that the vision is staying as healthy as possible, that the heart, kidneys, and the other organs and the bone health remains ideal are all things that we need to consider. That we know that if a mitochondrial patient is more vulnerable to crumping or decompensating during times of illness, that we protect them during those times. That if they're going to fast because they have to go in for surgery, or they're getting really sick and not eating and drinking well, that we put some precautions in place, whether it's through something invasive like relatively invasive like IV fluids, or just something else as far as starting supplemental feeding. It's something that we need to make sure that we have a plan put in place. And we do not want to harm our patients. So if we know that they have a mitochondrial problem, or maybe have a mitochondrial problem, that we don't want to poison them by giving them a medication that might hurt the mitochondria. And so there's a list of a few things, but there are no absolute no's. It turns out that other than something like Pol-G disease or Alpers, where you don't get valproic acid ever, there are very few absolute no's, but there is a laundry list of medications that the doctors at least consider trying to avoid whenever possible. And then comes down to supplements, and you may have heard of many of these, carnitine, coenzyme Q10, and the list kind of goes on. But I do want to talk about some of the ones that have a little bit more evidence behind them. Now, most of the supplements that have been studied have antioxidant properties. And so while they can maybe help the mitochondria work better, what they're really trying to do is help some of the damage that happens because your mitochondria are unhealthy, and trying to limit some of that damage inside the cells. And carnitine is one that has been studied the most. Now, if you got 10 mitochondrial doctors in a room, everybody would not agree on which supplement to give. You do end up getting about an 80-20 split on every supplement. So that kind of tells you where we are in our understanding of how these things work and how effective they are or are not. So I'm going to show you guys a video, and I want to caution, I show the video because many families who I've talked about this video but not shown it say, well, I want to see it. And I say, well, I want to caution you that this is one instance of where a supplement made a magical difference, which is why we try some of these supplements. Most patients, unfortunately, do not have a magical difference. But there is hope, and therefore it's worth trying these supplements on a directed or a cautious basis. So this is a patient that I'm going to show who has something called mitochondrial DNA depletion syndrome. His body cannot replenish his mitochondrial DNA pools. He was somebody who was unable to walk, unable to sit without support, was wheelchair bound, had a head strap, and the only change we made in his regimen was starting carnitine. And this is about a month after starting carnitine. This is about 3 months later. And this is about 6 months later.
Luke, come see me. I know that, Mom. Come see me. Look at you go, boy. Look at you go. Oh my gosh, I'm gonna cry.
So
Oh my gosh, Luke, look, come see Mom.
you can see why I'm cautious about showing this video. It's a wonderful video. It's heartwarming. I'm so glad that it worked for this child. In my 8 years of doing this, though, I've not had anybody else where carnitine has done this. It helps. It does help tone. It helps improve muscle strength. But I also want to use this as an example when families are sometimes a little reluctant to try some of these supplements that, you know what, give it a 3 to 6 month go. Because sometimes we do end up seeing magic and, then the side effects are not too bad. There's the talk about something called a cocktail. I'm cautious about starting a cocktail. This is my own thing. Many of my friends and colleagues, some with a lot more grays than me, start a cocktail because we know cocktails work better. These things work better in concert when they're tag teamed in. I start these one at a time because I want to make sure that no side effects happen. So I usually do these in about 1 month intervals. So I start medicine 1, medicine 2, medicine 3. If I don't see a big improvement after a month or two, I do talk about coming off of these if a family is interested. Coenzyme Q10 is another thing that has received a lot of study, and it is something that is often used in many patients. Coenzyme Q10 is available over the counter without a prescription. There is a lot of debate about whether certain forms of coenzyme Q10, something called ubiquinol versus ubiquinone, is better. And the research is a little bit all over the place on this. It just depends on who you talk to and who's presenting the data. Some people are very purist about only using certain forms of CoQ10, other people are not. We have the ability to follow cell CoQ10 levels, and so some of us say, buy whatever's cheapest, we'll follow your levels inside the cell, and then titrate your dose based on that. Folinic acid has gotten a lot of press recently, and again, the ones I'm going to show you are the ones where we actually have some evidence building up that they are really necessary and important. And so folinic acid is important for DNA synthesis, it's important for many chemical pathways to work, and you require energy to get it into the brain. And we know that some types of mitochondrial disease, but only some types have been studied, that you can't get enough folate into the brain. So your brain is deficient of folate, and because of that, it can contribute to injury to the brain as well as seizures. And so we do want to replace folinic acid. Now, folinic acid, even though it's a relative of folate, you can't just go to the drugstore and buy folate because it won't get into the brain. You need a prescription form of folic acid called folinic acid, which is leucovorin, and unfortunately, it's mostly been used for cancer and chemotherapy-related side effects. So your pharmacist might question why you're getting this, but this is one of the only proven ways of getting folate into the brain. There's another form of folinic acid called Deplin, which is methylfolate, and this is something else that is also or can be effective, though some people have had trouble getting insurance to pay for Deplin, because that has only been used up till now mostly for depression and psychiatric related issues. And insurance companies don't think treating those is as important. There have not been what are called too many randomized controlled trials done. These are the gold standards in medicine to see if these supplements work. And it's a challenge because, these are supplements, they're vitamins. We need money to do these studies, and unless you're going to spend your own money, nobody is going to support these. There aren't drug companies that are saying, I want to make sure that this compound works, so I'm going to give you money to study it. And so Dr. Tarnopolsky is one of those individuals who spent his own lab's money to study the effects of creatine, coenzyme Q10, and lipoic acid, and found that it did have some degree of efficacy in improving muscle strength and muscle endurance in a subgroup of patients with mitochondrial disorders. Another supplement that has received a lot of study recently is something called arginine. Arginine is involved in making a variety of things inside the cell, including citrulline and something called nitric oxide. You need nitric oxide to be able to keep your blood vessels open. And we know that in patients with a type of mitochondrial disorder known as MELAS, that you get little brownouts in the blood vessels of nitric oxide, and those vessels shut down, and you can get injury to the cells and cell death. And when this happens in the brain, we call that a stroke. And so for about 8 years or so, people have been looking at arginine in helping improve the ability of the body to make nitric oxide and prevent these strokes. And nitric oxide production does seem to increase in these patients, as well as citrulline, and the incidence of stroke seems to decrease, as well as the severity of the stroke when a person is in the middle of one. And so arginine has been used much more routinely in patients who have stroke, mitochondrial diseases that contribute or cause strokes. And these are just some of the other studies that have been done. There are some upcoming therapies that I want to mention. There is a drug that's being studied that many of you guys may have heard about. It doesn't really even have a formal name yet. The chemical compound is that thing at the bottom, alpha-tocotrienol, and then the FDA name is EPI 743, and this is something that still has not gone through human trials yet. It just went through what are called FDA safety studies. Will it harm a human being? The end of last year. And there have been very small pilot studies done in subtypes of mitochondrial disease to show that it may help. But the hope is that this company that has developed this drug, Edison Pharmaceuticals, will start doing what are called randomized, double-blinded controlled trials of this drug later this year or the year after that. That does mean that some patients will get the medication, some patients will get placebo, and it depends on how they organize the study, because there may be a potential for every patient to get the drug at some point in the study, but maybe not right off the bat. But we don't have enough information yet to know if this drug is going to help or not. What we do believe is that it definitely helps inside the cell. It might help change some of the chemical markers of mitochondrial dysfunction when we measure them using certain types of brain pictures, whether it be MR spectroscopy or other things. And and that's it. So one of the other areas of study is something called sirtuins and PGC1 alpha, and you can just think of these as regulatory switches, that these are switches that are very important that we are able to turn on and off, and these switches work very deep inside the cell, and when these switches are not functioning properly, the mitochondria cannot work well. Or if the switches are working extremely well, the mitochondria can work better. And people are looking at trying to modulate some of these switches and seeing if we can get mitochondria to work better. Now, one of the things that's gotten the most press is something called resveratrol. Resveratrol is made from red wine, or that's where we get it from usually. Unfortunately, you have to drink a heck of a lot of red wine to get enough resveratrol to truly be healthful in mitochondrial disease. So we don't recommend that. So if you're an adult, a little bit of red wine is not going to hurt. Resveratrol activates this whole cascade, and it can help improve mitochondrial production. As to whether or not this translates into helping mitochondrial disease, we do not know yet, and this is something that still needs to get looked at. Another thing that's getting studied is chocolate. There's a chemical from the cacao bean that goes by the name up at the top that can also stimulate mitochondrial biogenesis, and so this is another compound that's being looked at. Same story here. You can't eat enough chocolate to get enough levels in your blood or in your mitochondria to necessarily help, but you know what? It's chocolate, so eat as much as you want, and hopefully it'll help. So, but these are some of the actual studies going on. There's a whole lot of supplements I didn't talk about where we don't have active areas of research. It doesn't mean that they're not important. It doesn't mean that they may not help. It's just I did want to illustrate to you guys what is currently being studied. But there are things like alpha-lipoic acid, B vitamins, vitamin C, vitamin E, that have a little bit of science behind them and theory behind them, and maybe a little bit of evidence as well. But like I said before, if you get 10 mitochondrial docs in a room, and we did a little bit of this yesterday, everybody's got their own favorites. And that's an okay way to do medicine at this point in time, but it should not be the gold standard. Our gold standard should be a little bit higher. We should set the bar higher so that we know what we're doing is actually helping our patients. So I apologize for going over, but I do want to say that the next time you're faced with a scary, brave new world, which for many of you might be day in, day out, I hope you don't fear the witch of diagnosis or treatment that much, and that with this newfound brains, courage, and heart, you can help take yourselves and your families and your physicians to the end of the yellow brick road. Thank you.